Good evening, everyone. Uh, it is indeed an honor to be talking about Kasai's Portoenterostomy in the National Neonatology Forum, along with IAPS. I'm Dr. Arvind Sinha. So the objectives of today's talk will be to give a brief history of and the evolution of Kasai's Portoenterostomy, intraoperative cholangiogram, and what are the alternatives available to intraoperative cholangiography, the technical steps of Kasai's portoenterostomy, and what is the science regarding each step, and some of the factors affecting the outcome, and brief about long-term results of Kasai's portoenterostomy. So in 1968, Mario Kasai basically described the first definitive entirely surgical procedure for treatment of biliary atresia. And basically, this is the Japanese morphological classification of biliary atresia. We divide it into type 1, 2, 3, where type 1 and 2 are considered the correctable type, where type 3 we constitute 90 to 95% of all biliary atresia cases as the non-correctable type. So when should we be operating? When we started off, our basic rule of thumb was it should be operated within 90 days. Nowadays, 60 days is what is accepted. And the other thing was the patients used to present beyond 120, 150 days. And the question we used to ask quite often is, when is it too late to operate? So that was the thinking that when we started off with Kasai's portoenterostomy. The first step is basically intraoperative cholangiography. Is basically we make a small subcostal incision and inspect the gallbladder. If there is a rudimentary and it's fibrous, there's no lumen, we proceed with Kasai's portoenterostomy. If the gallbladder appears normal, failed to have a lumen, we secure a purse string and on the fundus itself, and we do go ahead with intraoperative cholangiography. If we aspirate, if there's no bile, or if there's white bile, we proceed to Kasai's portoenterostomy. If we aspirate bile, we go to intraoperative cholangiography. We have to confirm two things. We have to look for contrast flow into the duodenum. If there's no contrast flow into the duodenum, biliary atresia is confirmed, and we should go ahead and do a Kasai's portoenterostomy. If we can confirm contrast flow into the duodenum, we have to look for contrast flow into intrahepatic bile ducts. If there's contrast flow in the intrahepatic bile duct, our biliary atresia is excluded. If there's no contrast flow in the intrahepatic bile duct, we have to operate as biliary atresia. So it's a simple procedure to perform, but difficult to interpret successfully. Gallbladder commonly overlaps the bile duct on the during the radiography, and we need to tilt the patient a little bit so as the gallbladder gets out of the way. We have to have a purse string to prevent a leak. The contrast material itself is very viscid. If we dilute it, there's better transmission to the duodenum and intrahepatic bile ducts, and real-time fluoroscopy has been shown to improve outcomes in IOC. So this is both the examples of biliary atresia, where only the gallbladder has been visualized, no extrahepatic bile duct has been seen. In the second film, the duodenum is very well delineated, however, no flow into the intrahepatic bile duct. These both are examples of biliary atresia and should undergo a portoenterostomy. Now, are there any alternatives? Our medical colleagues have been evaluating using ERCP for evaluating biliary duct. In 29, Shanmugam et al. Used ERCP with a good sensitivity 100% and specificity of 87%, with reasonable technical failure of only 6%, and showed that ERCP could be utilized in the diagnosis of biliary atresia. Similarly, PTC, percutaneous transhepatic cholangiography, has also been utilized. Jensen in 2012 first suggested that PTC and liver biopsy can be used as one of the limbs in the algorithm for excluding biliary atresia. Para et al. In 23 suggested PTC for the diagnosis of biliary atresia. Sajka suggested it might be useful in patients of high-risk infants who are poor surgical candidates for diagnosis of biliary atresia. The surgical management proceeds further. We give a generous incision, mobilize the liver, deliver it out, and invert it into the wound. And then the portal dissection to expose the portal fibrous mass proceeds further. Then the question arises, where do you cut this fibrous mass? So Kimura in 79 basically did different level of cutting of the portal fibrous mass, where he cut it at the infraportal level, portal level. Alexa, thank you. Portal level and the supraportal level, and Kimura suggests, Alexa, stop the alarm. So intraportal, portal, or supraportal, and found that the portal level disconnection is probably the best. So with regards to the extent of dissection, Kasai's, there are three main modalities which are available. Kasai's, the original Kasai's, the modified Kasai's, and the extended Kasai's. Kasai, original Kasai's is gone out of favor. So the modified Kasai's and extended Kasai's, which is being utilized nowadays. Then we proceed with portoenterostomy, where a rule loop is brought and end-to-side portoenterostomy is made in a defunctionized rule loop. So, is there any literature about modified Kasai's and extended Kasai's portoenterostomy? Limited data is available. Our data is mostly for centers doing laparoscopy. 55 patients over 15-year follow-up, they found the jaundice-free interval in modified Kasai's was 80%, which was significantly higher than extended Kasai's, and native liver survival was also significantly improved using modified Kasai's as opposed to extended Kasai's. And these authors, especially Yamataka, has suggested that the risk of damage to micro bile ducts around portohepatis is minimized because deep suturing and extensive dissection is eliminated in modified Kasai's as opposed to extended Kasai's. Right? So similar results by another study by Yamataka, where modified Kasai's has better results than extended Kasai's. As I alluded to, Kimura's portal depth of dissection, they said portal dissection is portal disconnection is the best place to be. Extent or depth of dissection in 256 patients over 42-year period, Neo suggested that each decadal they changed their strategy, operative strategy. In the first 2 decades, they limited to outside the capsule, and they had 66 to 77% jaundice clearance rate. In third year, they had went inside beyond the capsule into the liver parenchyma, and they had lower jaundice clearance rate of 63%. And in group 4, where they cut the fibrous mass at the level of the capsule, they had 87.2% jaundice clearance rate. So Neo suggested that cutting at the level of the capsule probably has the best results. Similarly, with the rule loop preparation, the rule loop has been generally standards over decades, has been about 40 centimeters. However, the Japanese Biliary Atresia registry did a subgroup analysis in their cohort for patients where length of the rule loop was less than 40 centimeter to more than 40 centimeter, and they found no difference in the cholangitis group. Similarly, I think if you look at the anti-reflux valves, Suruga's procedure also, they found no difference as far as jaundice clearance and cholangitis is concerned using these technical modifications. Can we get away with using even a shorter rule loop? 40 centimeter rule loop in an infant might account for around 12 to 15% of the normal bowel length, small bowel length loss. So it will be obviously be better if we use a smaller rule loop. There's a randomized control trial which compared long rule loop with short rule loop and found similar results as far as clearance of jaundice and cholangitis was concerned. And the short rule loop in their study was only 17 centimeters, which is probably just enough to take the loop from the mesentery to the porta-hepatis. Once we've dissected, done the portoenterostomy, we send the fibrous, the excise specimen for histopathology. What do we look for in histopathology? The things we look for: the extent of portal inflammation, ductal proliferation is the hallmark of uh, biliary atresia, fibrosis, cholestasis, uh, bile duct morphology in the excise remnant, and bile duct size, portohepatis, and histological hepatocellular swelling are independent prognostic predictors of Kasai's outcome. So bile duct size at the level of the porta, one of the studies say less than 150 micrometer vis-a-vis more than 150 micrometer tend to have differing results. Recent studies are saying even 50 micrometer, more than 50 micrometer leads to better outcomes as opposed to less than 50 micrometers. So age of surgery, let's compare age of surgery and outcomes. Earlier, as we said, 90 days was the cutoff where outcomes tended to be better before 90 days and worse after 90 days. This Lakshman Rekha has migrated and evolved over the years and decades to 80, 60, 40. 60-day cutoff, we will be happy if our residents tell us that 60 days is the cutoff. Japanese registry over 3 or 4 decades, their average age of Kasai's portoenterostomy has been 59 days. Recent literature suggests the best results if surgery is actually done in the neonatal period. So age of surgery and jaundice clearance rate, if it is done within the first month of life, Japanese biliary registry says 70% of these patients will have jaundice clearance rate. The jaundice clearance rate remains relatively plateaued and at the same level for up to 80 days at 60%. It starts decreasing beyond 80 days and often decreases precipitously after 120 days. Native liver survival is affected by age of operation. A native liver survival advantage is most marked in the age group of less than 30 days. And this difference can be up to 20% as compared to later delayed surgery cohort with delayed surgery. So age of surgery and native liver survival, within the 30 days, 37%, 25-year native liver survival is seen, whereas if it's operated beyond 90 days, it's only a 18% native liver survival at 25 years. So we have a hit of around 20% in our outcomes, if we operate early vis-a-vis later beyond 90 days. So, when not to operate, that is another question that surgeons and pediatricians and neonatologists would need to ask. Age alone is not a contraindication for doing Kasai's portoenterostomy. Poor general condition, cirrhosis, ascites, hepatopulmonary syndrome, portopulmonary hypertension, malignancies, those are contraindication. My general rule of thumb is if the patient can reasonably be expected to survive the portoenterostomy, we should offer it. If the patient has a risk of dying intraoperative or in the postoperative period, we tend to avoid doing Kasai's portoenterostomy. How is late Kasai's portoenterostomy compared to no surgery or primary liver transplantation? Fuke, in a large study of 424 children, compared late Kasai's portoenterostomy with no surgery group. Late portoenterostomy, 2-year native liver survival of 53% vis-a-vis 12% in the no surgery group. So at 2 years, most of the patients without any surgery would have required liver transplantation. And at 5-year native liver survival was 30% as opposed to 4%. So when compared with late portoenterostomy vis-a-vis no surgery or liver transplantation, results of late portoenterostomy is definitely better. If you overall survival in subgroup, the red line is the late portoenterostomy group, and we can see it is hugging the blue line of early portoenterostomy group as far as overall survival is concerned, and the green line is much lower. So we definitely tend to give a better outcome if we operate even in the late presenting cases. Native liver survival again mirrors the overall survival, where the late portoenterostomy group hugs the line with the early portoenterostomy group rather than the no portoenterostomy group. So it definitely is better to do a portoenterostomy even in late presenting cases. Now let's look at the long-term native liver survival. French national study has been done, which is a 40-year study in about 1,400 patients, which is a large study and one of the longest study. They offered a liver transplantation in 55% of their cohort. And the 20-year native liver survival was 26%. 55% liver transplantation and 20-year native liver survival, 26% native liver survival at 20 years. In the Japanese biliary atresia registry study, the liver transplant was required only in 39%, and their 20-year native liver survival was 49%, which was double of what the French outcomes were. So there's a wide variability in results, even in among developed nations. Coming on to the other long-term native liver survival, beyond 20 years is definitely possible. Beal in 2013 in a systematic review had collected 184 patients, and they found with 20-year survival, about 60% will have progressive liver-related complications. So in the end, I think the take-home message, if you look at it, Kasai's portoenterostomy should be offered to all except the select few who are poor surgical risk. Wide disparity in literature in the results is seen even in developed countries. Indian literature is definitely singularly lacking. Earlier, the better. May avoid liver transplantation altogether, at least in 50%, if not higher. Early diagnosis is the key, low threshold for intraoperative cholangiography. Singular lack of Indian data is there. Laparoscopic modified Kasai small loop might be the way forward as far as surgical colleagues are concerned, the technical modification. And sequelae of liver-related complication persists in the long term. Thank you very much.